So, Module 3, we're going to continue talking about major neurocognitive disorders and getting into a little more depth. And the first thing is, how do we go about assessing these type of issues as we come up? So, one of the ways, and very common, is doing what we call mini mental state examination. And it is something that is pretty standardized. If you go in to see a psychologist and they have any questions about your mental state, they're going to ask you a series of questions. The first is your orientation, like what is the year, the season, the date, the day, the month, where are we right now, that are they oriented to their place. The next type is registration. So it's things like name 3 objects using 1 second to say each. And then you ask the patient all 3 that you've just said to them, and you give them 1 point for each correct answer, as you can see in the scoring there. Attention and calculation, you can have them count backward from a given number by subtracting 7s. And alternatively, they can spell the world backwards. So this requires a little more than just rote memory. You have to be able to actively use your short-term memory and problem-solving process to keep that in memory long enough. Your recall, name the 3 objects that you learned above in the registration part. And so you're looking at some of their long-term memory. And then finally, looking at language, where they name a pencil, a watch, repeat the following, no ifs, ands, or buts, following a 3-stage command, reading and obeying something like close your eyes, writing a sentence, and copying a design. And all of these are meant to really get at the orientation to time and place, anterograde amnesia, which we talked about in the last module, agnosia, aphasia, and apraxia. So all of those areas are covered in this mini mental state examination and can give us a better idea if somebody is suffering from some of these neurocognitive disorder symptoms. Now, if we wanted to do a more thorough, because obviously the mini mental state examination is a fairly quick one, you can give a neuropsychological assessment. And this is going to be an evaluation of performance on psychological tests. And the whole point is to go ahead and indicate whether a person has a brain disorder. And they'll do that using psychological tests that really evaluate the sensory motor, perceptual, and speech functions. And so it'll be a series of items that try to give a person a reason to give certain responses to illustrate whether they have those capacities or if those are somehow impaired. We talked a little bit about dementia having personality issues. Having changes in personality is pretty common. There's also motivational problems that can be associated with it. As far as emotions, they tend to be more kind of a flat affect, so apathetic, just not very emotional. So you might be thinking by this point when we're talking on this slide, boy, that sounds a lot like depression. And we will talk a little bit more about that in this module because depression and dementia can overlap to some degree. There is also hallucinations and delusions. That occurs about in 1 out of every 5, or roughly 20% of cases. It's going to be more common in the later stages of the neurocognitive disorder. And some of the common themes that you see with these hallucinations: phantom house guests, personal persecution, people are out to get me. And then not only do these symptoms overlap, but during those moments of maybe lucidity where they realize what is going on with them, depression is very common. As you might imagine, knowing what you used to know, but not being able to access that anymore is quite debilitating. And knowing that it's not going to get any better, you can see where depression would be a very natural reaction to this. But it's not just depression. Sometimes emotional reactions may become very exaggerated and far less predictable than you would typically think. There's also going to be some changes in motor behavior. There's an increase in agitation, so being somewhat irritable, having to kind of move, and yet there can also see this kind of muscular rigidity that is also part of dementia. You may see them do things like wandering away. They may pace kind of restlessly back and forth. And then, like I was saying earlier, depression and dementia do overlap, with about a quarter of dementia patients having the same symptoms of major depressive disorder. And so, once again, comorbidity does not miss neurocognitive disorders, and it is common, like it is with many of the other disorders we've talked throughout the semester. Here are some of the signs and symptoms and how you can distinguish depression from dementia. You can see with depression, it's kind of uneven in how it progresses. Sometimes they feel a little better, sometimes they really feel down, whereas dementia is kind of a slow and steady progression in these types of issues. Those who are depressed complain that they can't remember things, whereas those with dementia try to hide that they have some memory loss, so they're trying to compensate, even though they're not successful. As far as depression, a lot of times it's worse in the morning and gets better as the day goes on. Whereas with dementia, it gets worse later in the day that you get, or when individuals are fatigued, the dementia tends to creep in. Those who are depressed are aware of and sometimes even can exaggerate their disability, whereas those with dementia are not aware of what they have, and they try to minimize any issues that they're having. And then finally, depression. Those with major depression may abuse alcohol or other drugs, and in dementia, it is fairly rare for that sort of thing to occur. So there's a little bit of differences about dementia and depression, some of the personality and motor changes, and then how we might go about assessing whether somebody's just having neurocognitive symptoms. So in our next module, what we're going to do is delve further into the diagnosis of major neurocognitive disorders and go on from there.